All right. Good evening, everyone. Thank you for being with us tonight in the 21st West Coast Club meeting. Tonight, what we're going to have is basically almost like a debate on stroke. So the main topic is going to be stroke, and we're going to divide it into go straight to angio without doing CT versus not going straight to angio, or what are the benefits and also disadvantages for that. So Prof. Marius is gonna talk to us about like going straight to angio, and then Dr. Faisal Ghamdi is gonna go over the other way around, or what are the benefits and disadvantages for that. We're really happy to have you guys here with us tonight. We're really happy to have the participants with us tonight. Just few housekeeping stuff. This is an accredited with 2 CME hours from the Saudi Commission. There are no certificates. The hours are going to be entered if you register with your name and your number. It's going to be in your account maybe in 2 weeks or so. We're glad to have you here. We know that we all want to meet in person. We're sick of webinars, but I see like good number of participants. So thank you for being with us tonight. Without further ado, one of the things that I want to mention also here and announce for is that we are just doing more education. It's still going to be webinars on here until we open up again. And we're doing a specific program for fellows throughout the year as a curriculum for their teaching. So without further ado, I would like to welcome with me here Prof. Marius. He is actually a neurointerventional radiologist who did his training in Germany, Göttingen, and he is now the head of radiology and interventional radiology at the University of Basel. His interest is actually in stroke, and that's what he's gonna go over with us on tonight. He published almost like 89 articles, and he presented like almost more than 100 presentations here and there. So we're really glad to have him on board with us. We have also Dr. Faisal Ghamdi, who I personally worked with, and it's been a pleasure to work with in the last 4 years. I live the place where he's working, so it's a loss for me, but it's been really a pleasure to work with him. He did his training in France and then his subspecialization also in Belgium. And he's been practicing neurointervention for the last, I think, 6 years or so. And he has done a great job, and he's doing a great job also on stroke. So it's a pleasure to have him. And also with me, Dr. Ziad Al-Araini. Please, Dr. Ziad.
Thank you, Dr. Momin, and welcome everyone, and thank you for the invitation. I am a neurointervention consultant at King Abdulaziz Medical City in Riyadh. And I've done my training, residency, and fellow at Strasbourg University in France. So this is the summary. So thank you again, Dr. Mamoun.
Okay, so we'll start first with Prof. Marius, as we said, and then we're going to go with Dr. Al-Ghamdi, and then after that, we're going to have questions. So Prof. Marius, please.
Well, thank you, Dr. Al-Mamoun, for this introduction, and thank you for the invitation. I've never been to your beautiful country, so I find it really unlucky that I'm only electronically with you today. But I hope this whole pandemic is going to be over at some point, and then I would really like to meet you in person there. Can you see my slides?
Yes,
yes.
we can.
Yes, great. I will continue with my presentation. So I will talk about going directly to the angio, and of course, forgetting CT and MRI as scanners. You can see here my disclosures. And I start this presentation usually with the question, when do I bypass CT and MR scan? And the answer is never. And that sounds kind of strange, because we said I want to go directly to the angio, but the point is that we actually only bypass the scanner, so the room where the CT and the MR is, and then we perform the CT with the angio. So when we have a patient which is who has an NHSS of over 9, so he's very he has strong symptoms, strong neurological symptoms, then we count the NHSS, and if it's over 9, then we go with him directly to the angio, and then do a CT in the angio. That can be done, and then go on and do the thrombectomy if we have a large vessel occlusion. And the reason is that we used to be slow. So if you check here the numbers from the trials in 2015, you can see that there was a door to groin time of around 104 minutes in the whole trials. So even if in ESCAPE was the fastest of the trials, you can see they needed 80 minutes from the hospital door to the groin puncture. And that's a lot of time if you're treating stroke patients. You would say, okay, that was back in 2015, and now we're becoming faster and faster. But if you check here, that's a publication from 2018, and you can see the time is still 100 minutes from door to groin puncture. And also I have here the results of the ESCAPE NA1 trial, which was published in 2020. Again, that's the ESCAPE group, really fast guys. And you can see 80 minutes from CT to reperfusion. And if you control that with the first ESCAPE trial, you can see here that we have really the same time, 84 minutes in the first ESCAPE trial, 83 minutes in the second ESCAPE trial. So even the Calgary guys in the ESCAPE group didn't get any faster with time. And the problem is, if you check what the cardiologists do, they can do the treatment within 60 minutes from door to balloon. So the question is, can we be faster? Should we be faster? And the answer is, of course, we can and we should. And we can do that with a one-stop management. So instead of going to the neurological examination, to the CT, then the angio suite, and then the groin puncture, which if you're really, really fast, you can do in 60 minutes, you can go directly to the angio suite, do the CT, the CTA, and even now the CT perfusion with your angio suite, and then give TPA if you see a large vessel occlusion and perform your groin puncture. And you can do all this in 30 minutes. So the net gain, if you do that, is more than 30 minutes. And how you can do this? You can do this with a new angio machine. So this is the Artis Icono, the latest generation of the Siemens angiography, biplane angiography suite. And you can see that with this rotation, you can actually acquire a CT and then have the exclusion of the hemorrhage. So you can see here, that's the comparison. Of course, it's not as good as a normal CT from today, but it is good enough to exclude a hemorrhage, to give TPA, then do the CTA, and then go on and do the thrombectomy if you see a large vessel occlusion. And again, these are some images from the latest generation, the Artis Icono, and you have some new technologies here. It's really fast with 7 seconds. And you also have this sine spin technology, which improves the image quality in the infratentorial region. And these are images of DynaCT. So that's not a normal CT, that's a DynaCT performed in the angio. And you can actually see how good the image quality is nowadays in the infratentorial region. And again, for me, it's really important to compare apples with apples. And if you compare the flat panel CT, the DynaCT of today, which is on the left side, with the CT from 2000, when the TPA trials were done, then you can see that actually today, the flat panel CT, the DynaCT, is better from the image quality. So a lot of neurologists may tell you, well, what about the small bleeding? We don't see that, we can overlook that, and then we cannot give it TPA. In our experience, and we have done over 300 one-stop stroke patients now, you can do this safely. So then, after doing the non-contrast CT, we do the flat panel CTA. this can be done with normal intravenous contrast media. You then do a bolus tracking with your DSA, and then you have a multi-phase CTA, where you have an arterial phase. You can see here nicely the occlusion. Actually, you can see that's a distal carotid occlusion. And then also in the later phases, you can see the collateral filling. So that shows you there is little infarct core, and you can actually go on and treat your patient. With the same scan, you can have information about the carotid. So here you can see that from the same scan, you can see there is no tandem lesion in this case. And also today we have the option of a multi-sweep. So 10 scans with contrast. And then from this 10 scans, from this multi-sweep, you can reconstruct a normal CT perfusion. And you can also do this with rapid angio. So then you can calculate your maps that you know from rapid. And you can see here, this is a case that we have done recently here in Basel. You can see a small infarct core. You can see a really big penumbra. And then from these maps, you are sure that you can go on and treat the patient. That's what we did here. You can see on the CTA that there was a middle MCA occlusion. We went on and treated this patient. Those were the perfusion maps from Singo. So you can also post-process them with your normal Singo software. And then you can see here that after treating this patient swiftly, so you can see one pass and then a TK3, we had this DWI after 1 day. And you can see here that's actually pretty narrow to the lesion that we saw on the rapid cards. So again, that's feasible today. So you can have this in your angio. And you have the whole palette now. So you have the non-contrast CT to exclude hemorrhage and give TPA. You can have a CTA to check for the carotid and also the LVO intracranially, and then go on and do the perfusion if you have patients that come in the later windows and have your perfusion maps. We have published this concept in the past, first with 30 patients, published in stroke, then with 230 patients. And we could actually show that we are really fast and faster than before. So you can see here always the first 30 cases and then the 230 cases. And you can see that the door to groin times are really good, with around 30 minutes in the whole 230 cases. And also for me, really important, the door to perfusion time with around 70 minutes is near the goal that we have from the cardiologist with 1 hour. And if you check only the N1 occlusions, which can be opened faster, you can see here that we have a door to reperfusion time of 64 minutes. Of course, we compared this to the normal workflow patients, and you can see that we have a net gain of 40 minutes with this one-stop shop. What is really important, in my opinion, is also this second number. So we have calculated the 90th percentile, and you can see that with the one-stop shop, you can treat the majority of your patients, 90% of your patients, within 100 minutes. And that's just great for all your patients, because this means that the majority of them will benefit from the time gain that you have. What about the clinical outcome? We have also done some analysis on this compared to the normal workflow cases. And you can actually see we have a gain of over 20% on good clinical outcome. Of course, the point is the cases also had better perfusion results. And you can see here, initially we had 70%. With the new workflow, we have around 90%. So of course, this outcome, this better outcome, is not only a factor of the time, it's also a factor of the reperfusion, the better perfusion that we have. Again, time is really important, but also reperfusion is very important. And those are all numbers from Göttingen, where I used to work. Now I'm in Basel. So I will show you some cases as we have transported, as we have changed this protocol and implemented it also in Basel. And you can see here's the first case that we did, and it was actually a bleeding. So you can see here there is a thalamic bleeding on the right side. There is also an older infarction on this ACA territorium, but there wasn't any intervention to be done in this case. We go on to the next case, again, another bleeding. So we've kind of a lot of bleedings in the last couple of months here in Basel, but you can see here again, you can see the bleeding. You can be sure that you don't give TPA to this patient, and also the patient didn't have an LVO. This is another case with an occlusion, and you can see here nicely the clot in the inferior trunk of the M2. And you can see on this Dyna CTA that the image quality with contrast is really, really good. So it's even better than normal CT. Again, for non-contrast, it's not as good, but it's sufficient to exclude a hemorrhage. But with contrast, it's really, really good. And as you can see here, you can see the same clot on the DSA. We went on and recanalized this patient, and then he had a really good outcome. So do we have any data from randomized controlled trials for this protocol? There was one published study from Heidelberg, which I'm going to explain a little bit. And then just a couple of weeks ago on the International Stroke Conference, there was another published trial. So really, really important data. On this first trial from Heidelberg, you can see that there wasn't any gain for the patient. So they could show, and let me show you the numbers here. They could show that the time from hospital admission, from the door to imaging, for the normal workflow patients were 12 minutes, and for the direct to angio patient it was double. It was 20 minutes. So again, I find this a little bit how can I say, maybe not what I was expecting, because I would expect that it's similar or even faster with directly to angio. But again, that's something that we have to take in account. And then from door to groin, it was the same time, so 40 minutes, no gains here. And overall, if you take the imaging to reperfusion, you can see that they were really, really fast with a normal workflow through the CT, but they weren't, or they were fast also with a direct to angio, but there was no difference. And again, that's something that I find a bit strange, because if you check actually other trials from Heidelberg at the same time, you can see that actually they weren't as fast with a normal workflow in other trials. So again, probably there was some kind of bias in this trial, or the patients that they included were maybe transfer patients coming from other hospitals that you have imaging and you are ready and you can be really fast with the normal workflow through the CT. I will not discuss more about this trial, but again, regarding my interpretation of this trial, there may be a number of possible confounders. So again, I think they had a lot of drip and ship patients which already have an imaging, and then the CT is already ready for the patient coming. So unfortunately, there wasn't any information on transfer and mothership patients in this paper. So I can only, think what might be a bias. But again, really important results from another trial from Barcelona, from Mark Rebo and his group, the AngioCut results, which again was published a couple of weeks ago, or presented in the International Stroke Conference. And here the numbers are more likely to the numbers that we await from the other data that we have. So you can see the door to groin time is 20 minutes, which is similar to the times that we have in our papers. But if you go through the CT, through the normal workflow, then you have a door-to-groin time of around 40 minutes, which is really fast, but we know that they are fast in Barcelona. And then if you compare it to the door-to-reperfusion times, you have around 60 minutes for the patients going directly to the angio, and you have around 84 minutes. So again, significant difference when you go through the CT. And of course, they also checked the outcome of those patients, and it was positive. So it was a trial that was positive in the end, because they could show that the outcome of the patient was improved if they went directly to the angio. And of course, safety was also important, but they didn't find any difference for safety. Again, this is a first from trials that will show maybe that direct to angio and one-stop management is good. We know that in France there is also another trial that's running at the moment that's testing the same question, and we also plan another trial in Germany and in Switzerland to actually test the same question. So I'm very excited about the results, and we should wait and see what they show. What we have done in the meantime is we've done a meta-analysis of the trials that exist out there with One Stop Shop, and you can actually see that the majority of the trials shows that you're faster, your door-to-groin times are faster if you go directly to the angio, and also your door-to-reperfusion times are significantly faster if you go directly to the angio, as opposed to going first to the CT and then to the angio. So altogether, my conclusion is that the new Icono angiography system from Siemens offers sufficient image quality for the exclusion of hemorrhage. You can reliably see large vessel occlusions, and you can also do a perfusion analysis with rapid. And of course, I'm happy that one randomized trial has shown that One-Stop Shop is good for stroke patients, and we are looking forward for the results of other trials. What I suggest, and I think it's really important, is that we have to become better, as Formula One guys have become better, and of course not accept that door-to-groin time is going to be around 60 minutes, but aim for door-to-reperfusion time of 60 minutes in the near future. So thank you very much for your attention, and I think now we go to the next presentation, and we will discuss in the end, right?
Thank you, Professor Marius. It was really interesting and an eye-opening. We will start to the second presentation by Dr. Faisal, and we'll leave the question at the end of the presentation. And please, if anyone have a question, just submit them at the icon below in the question and answer subtitle. Thank you. Dr. Faisal, you can start.
Hello. Yes, you are hearing me?
Yes, perfectly.
The slide, it's okay. The presentation is
clear. Just make it a full screen.
Okay.
Presentation.
Okay.
Yeah, this is perfect.
When I start to prepare this presentation, I had no idea what Professor Marius is going to present, but you know, this is a new subject in stroke, as Professor Marius raised, that we need to go fast. As you know, with the cardiologist, their benchmark for timing is less than 60 minutes. For stroke, we're still far away from this benchmark. And we are trying to do many things to improve this. However, you know, the fact that we are dealing with different pathology that need more organization, more collaboration, and more imaging, more investigation to reach the right decision for treatment, for treatment endovascular or no. So I will be like not with or against. I will just present what I found and what I think it's sometimes facts, and we will leave the answer at the end for all of you. So, you know, I will just, I make it simple presentation because I know there is a lot of audience here. They need to know the basic and what we are talking about. And then I will go slightly deep. So just to start with, we know that from the beginning that the large vessel occlusion is less likely to be recanalized with the TPA. That what makes us think from the beginning how to recanalize this large vessel occlusion. And from here started the idea of endovascular treatment. Also, we know that with large vessel occlusion, the patient will have more poor outcome and higher chance of stroke disability. So early and other things, it was that the early recanalization associated with good outcome. This was proven from the beginning. We start to think about pharmacological endovascular strategy. Some of them showed good benefit, but with a lot of complication. And that was stopped. Then techniques improved with time. We had Mercy device in 2004, Penumbra 2008, Solitaire, then Tribu. And these devices lead us to have more chance of intracranial recanalization of large vessel occlusion. You can see here published article in 2011 before even all these studies that prove in the endovascular treatment, and it showed the chance of endovascular recanalization with the site of the occlusion. Since that time, the endovascular treatment became standard care in many centers worldwide, even before all the new studies randomized that prove in this treatment. Unfortunately, you know, in 2013, we had two studies with a lot of defects published in New England showing that there is no benefit of endovascular treatment, but immediately 1 year after we answered the question with this fantastic study, and I encourage all who is going to work with the stroke, even the nurse, the technician, and the angio. This is the main study you have to know to understand what we are talking about. Endovascular treatment is the famous study, Mr. Clean. And in this study, we get the first conclusion that, and from here we start, many other studies started after this, when we got the conclusion that the endovascular treatment is superior than TPA alone for large vessel occlusion. However, with selected criteria, that means not all the patients with large vessel occlusion will be included in this study, and not all the patients with stroke will also benefit from endovascular treatment. So patient with high NIH score, less than 6 hours, he will go to the CT and CTA. Why? Because we need to have aspect of more than 6 and to prove in large vessel occlusion. Then we move the patient to the angio to get the recanalization. As you can see here, you have the aspect with the CT, M1 occlusion, then shifted to the angio for treatment and recanalization. And the study, however, showed that you are improving the outcome by 32% comparing to the group that will not benefit from the endovascular treatment. And it became in the guideline. This is the updated guideline. And you can see here, this is the main criteria, pre-stroke modified ranking 1, 0 to 1. Sometimes you can say 2 even. occlusion of large vessel occlusion, NIH more than 6, aspect more than 6, and treatment can be initiated within 6 hours. With time, we start to think about timing. What about if we extend this 6 hour? Patient came more than 6 hours can benefit from the endovascular treatment. This studies answer this question. RIVAS-CAT studies that with selection of aspect, aspect is more than 6 or equal to 6, more than 6 hours and less than 8 hours. These patients also can benefit from the endovascular treatment. What about of more than 8 hours? Now the new update is 6 to 24 hours and 6 to 16 hours. And it's now in the guideline with, of course, selected criteria, which is imaging selected criteria that you can, with CT perfusion, MRI, and diffusion MRI plus minus perfusion, to select these patients with mismatch and large vessel occlusion to be candidates for endovascular treatment. So you can see from the beginning, the imaging is cornerstone in patient selecting. We are talking about CT imaging, MRI imaging, and this kind of imaging, what really allowed us to extend the window and to make it up to 24 hours. And this is the new advanced in technology of imaging, like the perfusion and understanding the perfusion, make us to be more comfortable to treat patient up to 24 hours from treatment. Other criteria also you can see in this that about aspect, large vessel occlusion, and NIH less than 6. These also ongoing, and you have many publications that, for example, aspect less than 6 for young patient, they may benefit. Large vessel occlusion, when you are talking like example of this case with low aspect, but young patient, 32-year-old. So we push this patient for angio, which is clearly justified for such patients. And for example, such case that you have M2 occlusion with high NIH 10 young patients. So here it can be more justified to treat this kind of distal occlusion. So you can see that even with the aspect and the distal occlusion, there is more toward that, okay, select the patient that can benefit from the treatment. And you can have here the new guideline talking about all these things. Many studies published about the endovascular treatment extend up to 24 hours. The question now that we want to solve one thing is the time. So we thought about the aspect, the large vessel occlusion, the time here, that we extend the time from 6 hours to 8 hours to 24 hours. But what about the time here? This is the line of the time that usually inside the hospital and inside the institute. We are not responsible about the time. I mean, directly, indirectly, we are responsible in many ways, like patient education and other things. But the time before the patient arrives to the hospital, we are not involved really. We are involving here in this line, the time of the line of the patient when arrive to the hospital. And you can see this is, even with this draw, it's clear when you have multiple line, upward, downward, that mean long time to achieve the recanalization or shifting the patient to the angio. But if you have a straight line like this from NIH score suspected for large vessel occlusion, shift the patient to the angio, as Professor Marius mentioned. But also something very important, you can see here that something very important here, that the early recanalization and the early reperfusion was really associated with the good outcome of the patient. Something also, if you are looking like this article that's showing huge cohort and the number and a lot of center participated in this study, that the average time from door to imaging is about 12 minutes, 7 to 20 minutes. And this is usually the benchmark in the higher center for the treatment of the stroke. And you can see the time, the average time. And here I'm talking about well-organized, well-established center that doing a stroke since long time and endovascular treatment even since 2006 or 2008. You can see here 98 minutes, the average time, and it's ranging from 68 to 126 to shift the patient to the angio, so not the recanalization. So we are wasting a lot of time here from arrival of the patient in the ER to shifting the patient in the angio. And you can see here something Professor Marius talked about it, and it's very interesting that less than 3% of the patient with a stroke had or achieved first pass treatment in less than 60 minutes. So comparing to the cardiologists that they are almost 80% in the best scenario of patient achieving treatment or endovascular treatment within less than 60 minutes. In stroke, we are less than 3%. So here is something to work with, and really we need to improve it. Also, you can see here that in this article showing the association between the time to treatment with endovascular reperfusion, that the early reperfusion and with the patient due to large vessel occlusion treated in routine clinical practice, shorter time to endovascular reperfusion therapy was significantly associated with better outcome. We are talking about 87 minutes here at average time. So what about if we bypass this two-step and shifting the patient immediately from ER with suspected occlusion to the angio, and of course less than 6 hours. But what type of patient, what type of subgroup of patient that we have to shift to the angio here? A lot of patients, you will receive many patients per day with NIH 6 and more, and sometimes NIH 5, and you do CTA and nothing and no occlusion. So if you are thinking to shift all the patients to the angio, this will be really difficult. But let's make it that we are thinking to shift group of patients here, bypassing this two-step, shifting the patient immediately to angio, having angio machine that allow us to study the aspect and confirm the large vessel occlusion with cone beam CT, so we can take the decision immediately in the angio for the treatment. We have a score, it's very interesting score, the rapid arterial occlusion evaluation scale, RACE score. That is above 5 of this scale, above 5 or 4, it's very specific and very sensitive. So when you are saying patient is 4 and above in this score, he has more chance and more likely that he would be suffering from large vessel occlusion. So this will be changed like this. Let's say high NIH score, RACE more than 4, NIH more than 10, less than 6 hours. Let's take this group of patients immediately to angio. Of course, you should have team ready in the angio. Neurology, interventionist, anesthesia, nurse, technician, 24 hours. And in new angio, you will have your aspect, you will confirm large vessel occlusion, then you will go to the treatment. Of course, it looks simple and easy when we are talking about it, and we can minimize significantly the time. If you can see the line of the time here, if you are going like this straight, reaching the treatment, we will be almost at the same level at the time that we need to do imaging. So the time that you will treat the image is treating the patient is the time that he may need only just to do imaging to confirm occlusion or aspect that you can confirm it with a new angio machine. From here, this trial showed also by the Professor Marius AngioCat, they took these criteria and they designed this study that NIH with two groups, race more than 4, NIH more than 10, less than 6 hours. We have group shifted to the CT and CTA, and group will be shifted immediately to angio, of course, with team ready in the angio. And then in the angio, we will have the beam or cone beam CT to confirm the aspect, no hemorrhage. Even you can start the TPA if the patient is candidate. You confirm the large vessel occlusion, and then you do the treatment. Or the other group that will go the classic way from the imaging, then decision to the angio. The study is published, and recently it's not yet published as article, but this is presentation in Stroke Society. So you can see a very interesting door to puncture time from the group will be shifted to the CT about 42 minutes, and 18 minutes for the group will be shifted to the angio. Of course, door to reperfusion time also significantly decreased, and something very important, that you improved the outcome of these patients by 1 point in the modified ranking scale. Sound really interesting. But if you take this first thing we are talking about, that we need new angio machine, as Professor Marius showed, you have you need this angio machine that can do cone beam, can do expert CT with injection, venous injection or bolus injection to confirm the occlusion. Sometime you may need it to do perfusion for these patients beyond 6 hours. So how many like this machine we can have by center, by city, by country? It's really difficult. I'm still working with such machine. So this is also in good center and high center. And then other machine, they're still working with monoplane. So if we make it more strict that you should have this kind of machine to do this kind of, and to accelerate the process of treating the patient, I'm afraid that a lot of centers that treating a lot of patients, they cannot do it. And they, with time, they will stop. And we start to talk about something out of what you used to do. And we are thinking about subgroup, and we will forget a lot of patients that can get access to this treatment with a little bit longer time. So here it's really difficult to decide about this. Another thing, here you need 24 hours team ready in the angio. Neurology, interventionist, anesthesia, nurse, technician. Also, again, even with the day work time, seems difficult because some of them will be working in other angio, or anesthesia will be busy in OR. You will need 15 minutes to come to you. So what about in-call time? It's really difficult. And if you really make it, you want to make it successful, you have to have 24 hours cover of stroke team, including neurology, interventionist, anesthesia, nurse, technician. And I think will be difficult in terms of organization and in terms of cost effectiveness. So another things, if we are talking about this, we are talking about this group that NIH, then we have to divide it in subgroup. NIH less than 6 hours will go to the CT. NIH with 10 raise more than 4 less than 6 hours go immediately to angio. NIH with more 6 and less than 24 hours. You need perfusion, sometimes can be available on the angio, but not always. So we are, I think, making like this. We are making it more complicated in subgroup analysis. We are dividing the patient. And this is really difficult if you are talking about primary center, that you will spend a lot of time to learning and teaching people about NIH score and race scale. So this can sometimes be really complicated. It's easy in some center that they are doing stroke since 2000, again, 2002 or 2006, but the center that growing now, this is really will be difficult, I think. So sound good, but again, when you are talking about the new angio machine that can do beam CT and cone beam CT, and again can confirm the large vessel occlusion, what about the cone beam CT? We still talking about aspect as very important and very cornerstone criteria for patient selection. We can go down aspect 4, aspect 5 for selected patient, but still aspect. Still, we are talking about aspect. Aspect good, as you can mention in the cone beam CT. But I think here we will need more studies, more comparative studies to really confirm, is it good enough to select the patient for treatment as aspect score, or we are going to treat more patients with aspect of less than 3 or 4 that it's not clear in the cone beam CT, and we are entering now in chain of studies confirming by another studies or controversial by another studies. So this is another question to answer. Is the cone beam CT in an angio machine, and the new angio machine, is very sensitive and specific enough to decide about the aspect score? This is something. So again, for the pre-endovascular treatment, Professor Marius showed that we can do high resolution CTA to confirm the site of occlusion. This is interesting, but it's again not available on all the angio machine. And sometimes you need to study and you need to have idea pre-treatment. If we are doing the CT head and neck for all the stroke patients, and for example, for such cases that you need to know pre-treatment about the site of occlusion, type of occlusion, what material I'm going to use, what approach I'm going to do, how I'm going to prepare the patient. However, you can discover this in the angio, but sometimes if you go straight with clear plan in your head for the treatment, I think it can be better. Also, sometimes also the variant, the CTA, that you can see it clearly, unless you have the angio that can do the expert CT with the bolus injection. So again, sound good, but cost. We are talking about sophisticated angio machine, new generation of angio machine, team to be ready 24 hours, neurologist, interventionist, all the team. This will be a little bit cost effective. And if you are talking about what is the cost effective, and is it really 1 point changing in the modified ranking scale needs all this disorganization and reorganization of the stroke center that will need a lot of time to achieve the results that can be achieved in, again, specific center like Professor Mario's center or Barcelona centers. So again, we will open more and more questions. We will need more and more trials and more small details to answer and to work with to reach the strong conclusion that we want to reach. Again, sound good, but how many of this group of the patient that you will shift to the angio? I didn't see the detail of the study. Professor Maris probably tell us idea how many really patients that shifted to the angio and he had no occlusion or no large vessel occlusion. If you didn't have really specific software that can do this expert CT with bolus, venous bolus, that you need to go to the cerebral angiodiagnostic, invasive procedure, unnecessarily procedure, again, cost effective. And is it medical legal to expose all the cohort group of the patient with a stroke to this invasive procedure, for example, to select group of the patient to give them one more point in modified ranking scale? Another question to be answered. So again, sound good. So the second question, is it better now after this conversation, after this presentation from Professor Marius and from me, is it better than what shifting the patient immediately to angio? Is it better than what we are doing now? I will leave this for your vote. If your people in chat can just vote, write yes or no. Let's see how you start. Please, people in chat, you can just write yes or no. Is it better? For audience.
Yeah, in Q&A you can add.
No answer?
Yes.
Yes, yes. Better, but so we can see yes, yes. As you said, no. No. Please, I need more answer. Either we agree or not. Better if you have the right angio system. Good. So we still say better, but okay. Is it difficult to apply? Good. More answer? People who answer is really the people who understood what we are talking about. Okay, yes. This with the Professor Mari's group saying yes. So we will have a lot of discussion, a lot of argument. Some they will say yes, some they will say no, some they will say we have to wait. For me, really, I say it is better, but many condition. And of course, if it wasn't better, it wouldn't be perfect. And I think we're still far away to say it's perfect. We can say sound good, it's really good, when you apply it the right way in the right system with really well-established stroke center that doing this since long time, good number of staff. For example, I would do this, for example, if I had 2 or 3 fellows of neurointervention that they can be available 24 hours in angio, and they can cover the stroke neurologist, they can cover it, for example, with resident anesthesia, they can cover it with fellow. So it needs more organization and it's need more time. I'm sure the results what's shown by Professor Marius and by Barcelona teams is right. And this, what can really happen if you have this pathway and this system. But in reality, it's not easy. We still facing a lot of problem and a lot of time waste just to shift the angio to the CT, just to confirm if the patient is candidate for TPA. So something very interesting, but don't forget about CT. That's what I can say for now. I hope someday I can visit Professor Marius Center to see how it's really working. This is really fantastic. This is really dream. I dream of it. But for our community here and many other centers, just don't forget about CT and let's take it smoothly. Thank you, Professor Marius. I don't know if you can comment about what you are saying and we can discuss.
I really enjoyed your presentation, and I think you're right. I mean, we cannot forget about CT, and in the end, I also understand a lot of the comments that it's not easy to do something like that. It requires a lot of effort from all the staff, and also of the head interventionalist, because you cannot just stay at home at night and wait all the others to do the one-stop and you don't do it. So. For me, it's really it's been a lot of work, but I enjoyed doing it, and it's something that you can then go to your hospital administration and show the results and try and get them to give you also more staff to do your work nicely, right? So that's something that has happened in Göttingen, and that's something that we can also start doing now here in Basel, because if you show the results, if you show how faster you become, then I think you can also convince the hospital administration to give you more resources. But it's not easy. I mean, I understand the comments. It's really not easy to do that if you don't have a lot of personnel. Just a small remark, because somebody commented that we should also go and buy Siemens angios now. So from my point, it was the other way around. I had this idea, and I had this, if you want, thought back in 2010 that we should start treating stroke as trauma. You know, when I was doing my residency, I remember when there was a trauma case, there were like 20 physicians in one room, and they all did something, and then after 10 minutes we had the decision and the patient was in the OR, right? And I remember seeing stroke patients coming, slowly without the doctor to the CT, and we would do the CT, then we would call the neurologist, we would discuss a little bit, then after like 10 minutes the neurologist would come and, yeah, we should give TPA. And what about intervention? Well, I have to call my senior, and then I would come, that's a completely different world. And so after, starting to have this idea, I also started to trying to get Siemens on board. And, Siemens in the beginning, they also were thinking, well, we have the CT, why do we need a CT in the angio, right? I mean, why should we go directly to the angio with our patients? So again, the angiocat trial from Macrebo, I think that was done with a Philips scanner. So again, you can obviously do it also with other scanners. I work with Icono now. I used to work with Siemens scanners. So from my point of view, I can say, yes, you can exclude a hemorrhage because we have done the trials with those machines.
And what do you think about the aspect score, Professor Marius?
That's difficult.
You are comfortable
That's difficult. I mean, I know you have to have a lot of experience to be able to do the cone beam CT correctly and also interpret it correctly. I can do it. I'm pretty sure I can do it because I have 15 years of experience with cone beam CT. But I think somebody who only has 2 years or 3 maybe cannot do it. But again, from my point of view, I know the studies you showed, and I accept your opinion, but within the first, I would say 3 to 4 hours, I don't think that aspect is so important. You know, there are a lot of trials showing that even in aspects of 3 or 4 is really is acceptable to go on and open the vessel. So if you do the CTA and you see really good collaterals, I don't really need the aspects. If I see good collaterals, I know this patient is going to have a good aspects. So
that means that this patient can stay more. So even if you go 60 minutes later, he will be fine.
No,
right or no?
No. I think time is we are.
Yeah, I agree, but just sometimes it's when we are talking about always I say I went with the patient to treat patient aspect, for example 9 and time up to 10 hours. I had no perfusion, and I say if he's maintaining aspect 10 hours, that means he has good perfusion. It's reflecting each other.
Sure, but still, I think this patient has an occlusion, and every minute counts. It maybe doesn't count as
gross
strongly
anatomy,
as in other.
but at the microscopy, it's count. We agree. Just I want to ask about. Really, I'm wondering about this. How many or what was the percentage of the patient that you shifted to the angio, and there was no occlusion? What was really this is very important.
So roughly, if you have a cutoff at 10 NHSS or race over, I think it's 5 or 4, then you have around 20% of false calls. So patients that don't have an LVO, just have a peripheral occlusion or have a bleeding. In Göttingen, we then shifted this back to 7. So we had the threshold at 7, and then we had around 30% of false calls.
But so with the NH7 and race is, I think race is more correlated with the occlusion. So if you say 4, for example, patient with gaze preference or head deviation, most likely he will have large vessel occlusion. So we are talking about 20% to 30% from NH10. You are talking from NH10.
Yes.
Okay. And what about the time beyond 6 hours? You do perfusion in the angio?
I wouldn't do a one-stop, a direct to angio with patients over 6 hours. We don't do it. We didn't do it in Göttingen. We don't do it here in Basel because, as you said, after 6 hours, you either have good collaterals and then every minute doesn't really count as much as in the beginning, or you don't have good collaterals and then you already lost the game, right?
So this group of the patient beyond 6 hours, you will go to the classic perfusion or down inclusion criteria to select your patient for the. So, and how many angio machine you have in the center? I know you are busy also with aneurysm, with AVM, with elective procedure, emergency aneurysm. How many? So you have one machine just dedicated for stroke. You have to.
No, not yet, but that's
how
the
you
plan
are doing
for the future.
If you are treating aneurysm, how I have to review your details. So if you are treating aneurysm, how you will shift the patient immediately?
Then we don't do a one-stop. That's as easy as that. If you have an aneurysm case and the angio is occupied, then you cannot do a one-stop. Then we do the normal workflow. But in the paper, in the comparison we did, we only compared it to cases that came and the angio was available.
Okay, so to make it group two arms, so you have really randomized. It wasn't
No, we didn't randomize. That's something that Mark Ribot did in Barcelona, but we matched control and we only took cases that came and the angio was available.
Okay.
So
what about the how you do the vascular imaging? You do like venous injection, then
yes, it's a venous
from head
injection.
and neck, complete head and neck.
Is normally as is your CT protocol. So your normal multi-detector CT protocol, we give 60 milliliters of intravenous contrast.
Okay.
And then you can do a DSA, and at some point you see the carotid coming, even after intravenous injection. And then you start with your scan.
And you can go up to the common carotid, so you can explore.
Yes, so you have the detector, which is like 40 centimeters. Good. So you have the carotid bifurcation and then the intracranial vessels. There is a new technology coming, which maybe will enable us to even have also the aortic arch, but that's something that will come in the future.
How many machines like this worldwide?
I don't know. I don't really know. We have, to answer your questions, in our center, we have 7 angio machines, but 1 dedicated for neuro. So if this is occupied and there is another stroke coming, we have other options where we can do
this
stroke.
machine with such option that can do good cone beam CT and
just one. Just the one.
Only one in your center. Yeah. And in Switzerland?
I think now there are 2. There is one in Bern and one in Basel.
Okay, and Genève with Paolo?
I don't think they have an Icono yet. Or
okay, and in France, I'm not sure if they have it everywhere. So it's something coming again, something very interesting, sound really good. I really enjoyed it. It was really another dream and stroke coming. It needs more time. In some center that needs a few months, in other centers it needs many years. So Dr. Ziad smiling, Dr. Mamoun is smiling. And thank you, Professor Marius. We leave for the audience if they want to ask.
Okay.
Thank you, both of you. Really, it's a very fruitful presentation and discussion, and it's really a great honor to listen for both of you. And really, it's an eye-opening again. Thank you both. If I may ask, one of the audience also ask a question, and they like it, if you can, Professor Marius, to go further in detail a little bit about it, about the challenges when you start this this method, especially like what is the challenging that you faced before starting this aspect regarding the human resource, the coverage, 24 hours, etc., etc. And the same question also to Dr. Faisal, if you want to start this method, what is the obstacle that you may face? So Professor Marius, please.
So I also answered it in the chat. The main problem is to get all the team on board, because you know, a lot of people have already worked a lot of years and they are used to a certain way of working and thinking, and coming with a new idea and then getting the whole team on board to change this culture, that's not easy. In Göttingen, I had a lot of feedback or a lot of negative force from within the team, because some people were thinking that's more work for them. But in the end, the majority of the team realized that it's actually less work, because you don't go to the CT and then you go to the angio, you go directly to the angio. So if you have a night shift, actually the patient gets his treatment 30 minutes earlier, but you also can go then to your bed 30 minutes earlier. Okay, so that's something that was in the beginning a bit tricky to explain and understand. Here in Basel, the team is or was a lot more enthusiastic about this concept, and what was a bit more difficult is to get the patient to the right room in the right time, because the structure is a bit different, so we cannot go directly to the angio. It has to go through the ER and then with a neurologist come to the angio. So it was more of a management change that we had to do. But again, that also worked, and we have this new protocol. But at the moment, we only can do this within 8 to 1600 hours. So in daytime, we haven't started doing it at night yet. So again, it's phase 1. We try to prove that it's a good concept and we are becoming faster. And the phase 2 would be to go to the administration and say, look, we are faster. Now we need more personnel to actually do this also at night.
Interesting. Thank you.
I think one of the main issue that we have, I did some review about our stroke endovascular treatment in our center. And something interesting I found that most of the patient, I'm talking about 80% of the patient, the femoral puncture about 5 hours from onset, recanalization 6 to 7 hours. And most of the patient received the TPA at the end of the window, believe me, at 4.5. So we, when I remember when I came and joined the KMC, or even in general in our many primary centers, they are not even giving the TPA. In many primary centers, you still have no clear protocol or pathway for stroke patient and for TPA. So I think we have a lot of works to do in pre-hospital step to get the patient in the good timing, so that we can talk about shifting the patient to the CT or to the angio, what is better, what is, we are trying to reach the patient at the end of window. This is what we are doing most of the time. So this is really main. Other things, if you are talking about new angio machine, staffing, all this is fine. But this means nothing if I have all this, but I'm still getting the patients at the end of the window at 6 hours, for example. This means nothing. So a lot of things to do with this, the pre-hospital, the pathway of stroke patient. You know, as Professor Marius knows, that Saudi Arabia is a really big country with a lot of cities, many primary center. It's not like Europe. I know the system in Europe, in France or in Switzerland, Belgium. You know, it's small and well organized, that all the patient coming immediately to the center without turning around. But here we are still, for example, I'm working with the city, that there is scattered small city around. And in each city, there is primary center. And this primary center need a lot of education, just how to receive the stroke patient and which patient he or they have to send to us. So a lot of organization to do here. Always I'm saying in Europe, I remember when the Mr. Clean came up, it talks about 1 day workshop in the hospital. I was in France, I remember. So it was 1 day, and only 1 day to arrange with all other teams, and just it went immediately, because you have already this chain of TPA. What you need is just adding something. But here we are in phase of creating the chain of a stroke patient of TPA. Then it will be easy to add the endovascular treatment. And what I observed here, and that many centers start talking about endovascular treatment even before talking about the TPA. And this is coming from from the bottom to down. So this is not working. You have to start from the basic, from 98, the TPA, then we can talk about, for example, 2014, the endovascular treatment. But if you are trying to, and I think it's something coming because there is this idea about endovascular treatment and the good result and the good outcome, but the TPA has also excellent outcome. And when you have this good pathway for TPA, endovascular treatment will come in the chain. So if we had this, then we can talk about more stuff, new angio machine. I really like to have this angio machine with Professor Marius. It's very fantastic for aneurysm and AVM. I really love it.
Yeah.
For a stroke patient, we have to think in the pre-hospital and the hospital pathway before we are talking about angio machine and stuff. I think this is what I think.
No, that's a great idea, and altogether, I mean, I see this also in Greece. I come from Greece, and if you check the number of TPA given or the thrombectomies, it's really low. So you cannot go to Greece and start talking about you know, going directly to the angio and doing one stop and not even have the basics, which is TPA and also the whole system that's working good here in Switzerland. But again, I think you have the ideas, and if you have the ideas, then at some point you can also implement this in your daily working life.
Sure.
And I would be happy to help if at some point you want to start doing a one-stop.
Sure. It will be really interesting here sometime that we can, for these patients, for example, if you have one day patient that coming with 2 hours of presentation, young patient, you are in the hospital or the team in the hospital, and you can just immediately bypass, okay, say this patient can benefit. This is what I'm doing, for example. Rivascat, talking about 8 hours of aspect. I'm using this in my daily practice, you know, without going to the perfusion or down criteria. So same things here, we can use it to specific cases for a specific patient. It will be more justified. For example, nobody will say why you shift this patient immediately to angio. So this gives us more freedom to select patient and to work, and then with time can be implanted in the system smoothly with improving all other the pathways.
Yeah.
Thank you.
Dr. Mamoun has no comment.
No, I do. I mean, but you guys are enriching the talk, so I have nothing to say. I mean, who am I to talk today? I really enjoyed both of your presentations, and not like a neurointerventionist, I really learned a lot, and I was listening with kind of smile on my face because all what I heard was actually great. And I really love what Prof. Marius is doing, but at the same time, I really love you being realistic, Faisal, because also it's good to actually look at what you're in right now and what's the situation in each country. So you can't apply everything everywhere, but you have to look into everything. And it's nice actually not to even like just dream about doing something while the infrastructure is still not there. So your answer was actually spot on. Abid here is actually a nurse who works with Dr. Faisal, and who I had the pleasure to work with as well. He was like requesting to have some training for nurses and techs and others to have like a stroke team as well as an initiative from SERS. And I think that's a good point to consider. So one quick question, I think we have 5 minutes to go with questions and then we have to wrap up. But one quick question for Prof. Marius to say, like, what do you think about the quality of cone-beam CT to detect bleeding?
So again, we have published a couple of trials on this, and a couple of papers with the older generations, with the last generation, and now we're doing the same with the latest generation. So if I have a patient that has an NHSS of 12 or 14, I'm confident that I can exclude the hemorrhage with the cone-beam CT.
Excellent. Ziad, you have a question?
I think there is one of the audience who asked a question. He said, Professor Marius, do all your patients that goes directly to angio receive TPA before thrombectomy?
Yes. So if we can exclude the hemorrhage and the patient has all the other criteria, he gets TPA.
And another question from audience, I think it's already been answered, but we want to highlight it to clarify things. The question is, no, it's okay, it's been answered. Is the patient do a CTA before the angio thrombectomy or no? It's been answered. Yes, the patient do CTA before angio through the quad beam. Okay.
I mean, regarding, maybe if I can add one last comment regarding the training. Again, from my point of view, we have a really good team of technicians here that do also do the DynaCTs. So in Germany, it was like this: the physician had to do the DynaCT and also the reconstruction of the images. Here in Basel, we have a great team of technicians that do the DynaCTs and also reconstruct. So if you're thinking, and I mean, they're the same angio techs that then also do the thrombectomy with us. So if you're thinking about, you know, trying to establish and train your staff, we can even think about some kind of exchange where, you know, techs from your side come to us for a couple of weeks and then they see how we do this live and maybe come back then with the knowledge and can implement that in your sites.
Sure. This
That's
will
actually
be
a great initiative and a great idea. Yeah.
Sure.
Yeah. And since we have no more questions, I think we will wrap up. But we really appreciate everything you guys have done tonight. It's been a very great and insightful talk from both of you. I love the dynamics. I love the talks, and each one of you has his own valid point, which was really interesting. I wish, you know, we can fly again and actually you can come to us. SIRS is actually happening.
I think this should be the last webinar because we got tired with webinar. I really, I find
but actually
it
it's good that it
now.
connected us.
Yeah.
You know, we got connected with people we know now. We have, you know, more people. We know more people now, so we can get connected. Hopefully, when things open again.
Sure.
And we have more
if I can add one last point, we have started a small YouTube channel on techniques and on you know, ways you can treat aneurysms and also AVMs. So if you go to YouTube and you click "one stop in stroke," one word, you will find some, I think, interesting videos and also commentaries on how to do some stroke techniques. And again, for your audience, maybe that's interesting. And I would love to see your comments.
Excellent, great. And we hope to have you actually on. We'll do the program and everything. We will have our annual conference for SIRS in November this year. So hopefully by that time things will open. And
I hope so.
Sign me up for the best restaurant in Basel.
Okay. Great.
Okay. Thank you so much. You want to add anything, Prof. Marius?
Great night.
You want to add anything, Faisal?
Thank you very much, Dr. Mamoun, for organization this. I know we talked about it since a long time. You initiated that you want part of your schedule to be neurointervention, and really I appreciated that you initiated. Didn't come from us, but as usual you are full of energy that can initiate anything.
Teamwork.
And I hope this will be continued. We can have it at least each 6 months, one of your presentation to be neurointervention presentation under the umbrella of SIRS. Thank you very much, Professor Marius. It was really interesting to have all these updates. Even if I yesterday tried to read a lot in PubMed, trying to figure out what we are talking about, and what you just highlight, it was really interesting and impressive, and answered a lot of questions for me that I spent all the night yesterday looking for answer for them. Thank you, Dr. Ziad, for joining us, and for this shiny face. You look tired. And thank you very much for the audience. I really appreciate it. I'm seeing good number, and we hope that we keep on. That's all. Thank you very much.
Ziad, you want to add anything?
Yes, thank you, Dr. Mamoun. As always, your dynamics give us the courage to go forward, and it's the fuel for our energy. Thank you. I appreciate everything. And as always, this is not the first time that you shine the energy for us. You're like the first sparkle that makes things goes. Thank you, Dr. Professor Marius, for your kind presentation, and it's really an eye-opening and very fruitful presentation. We really appreciate it. And hopefully that this will not be the last, but again, not in virtual, but in real life, physical presence. And Dr. Faisal, as always, your presentations are really magnificent and cover all the aspects. And really, like, I learn a lot from your presentation, Dr. Faisal, as always. So thank you everyone. And thank you for the audience, of course.
Yeah, thanks to all, Prof. Marius, Dr. Faisal Ghamdi, Dr. Ziad Al-Araini, Kunuz Ritaj for helping us, Siemens for supporting us, and for bringing us this gift of Prof. Marius. Thank you so much. Thanks for the participant for hanging up with us here. So appreciate it. Thank you guys. Have a good night.
Have a good night. Thank you.
Take care.
Thank you.